Good morning, everyone. This session is primarily the guest lectures session. Basically, we have guests from US and Australia. And I'm Dr. Lalit Verma, and with me, Dr. Harbans Lal, and more people will join for the chairpersons. Dr. Andy is here? Okay, thanks. So before I request Dr. Andy to deliver his talk on endogenous endophthalmitis, so sequence will be endogenous endophthalmitis, then a talk on under pressure about IOP after repeated intraocular injections. Remember, intraocular injections have become a very frequent procedure nowadays. So Dr. Nitin from Australia will be talking about IOP after repeated injections. Then Dr. Andy is going to come back and talk about the buccal procedures. And last we'll have Nitin again talking about sustainability in practice. Very, very important talk for all of us to hear. So Dr. Andy is professor and head of chair of retina services in Pittsburgh University. And there's a huge CV he has, but I'll read out the salient points. After having medical degree in Philadelphia, then residency at Wills Hospital, then fellowship with Charles Skipens, and he rose through all the academic ranks and is now professor and head of retina services in Philadelphia. And there are a lot of his publications, so I've selected few of them. You see, he has been working primarily on endophthalmitis, buckling, and detachment. So these are the list of his publications. Nitin Verma is presently the president of RANSCO, the Royal Australian New Zealand College of Ophthalmologists, and is primarily based in Hobart, Tasmania, Australia. And his research interests include macular disease, interventional health, and teleophthalmology. So many awards Nitin is recipient of, and in appreciation of his contribution to teaching and research, he was appointed clinical professor at Tasmania Medical School, and in recognition of decades of philanthropic work, he was awarded Order of Australia and Order of Timor-Leste in 2010, a very high-rated award Nitin received. And coordinated eye care work by doctors and optometrists, nurses, and various NGOs. Nitin is establishing a national eye care program in Timor-Leste to provide eye care to eradicate prevention of blindness amongst Timor-Seas. This is a very, very ambitious project he has embarked on, and wish him all the best for this. And as I said, he currently practices in Hobart Eye Surgeons and is a visiting ophthalmologist at Royal Hobart Hospital. And various achievements he has had, which are listed on the left-hand side. So I welcome both Dr. Andy and Nitin to this 80th conference of AIOC, and I'm very obliged that both of them agreed to grace this occasion. So at the first, I will request Dr. Andy to talk us about endogenous endophthalmitis, both diagnosis as well as treatment. Dr. Andy, please.
Good morning, Mr. President. Thank you. Thank you again for the honor of being invited to Mumbai and to speak to you today. I'm just curious as I look out, how many of you are hospital-based ophthalmologists? One? Okay. Is it one? Okay, let me see if I can advance this. So I'll tell you how I got interested in this topic, is that in our major tertiary medical center at the University of Pittsburgh, we serve Western Pennsylvania, Eastern Ohio, and parts of West Virginia. And because most of the sick patients that come to us come from other hospitals, about 30% of our admissions are patients with sepsis. And as we know, endogenous endophthalmitis is a complication of sepsis, and it can be somewhat difficult to diagnose in some patients for a number of reasons. Sometimes, I think, because they're partially treated for the sepsis with antibiotics, so that the eye manifestations can be less severe than we would otherwise expect from such an organism. The causative organisms may be bacterial or fungal, and they may, in North America, tend to be staph. I understand in Asia it's more likely to be Klebsiella, and in out of fungal organisms, Candida or even Aspergillus. The epidemiology is going to be variable based on what study you quote and what location it's performed. There are definitely known risk factors, which we'll discuss, and obviously there's limitations to the data that we do collect from epidemiologic studies. So a bit of background. My fellow at the time that we did the study, Malika Das, seemed to have this black cloud over her that every time she was on call, she diagnosed a patient with endogenous endophthalmitis. And I said, well, this is very easy because bacterial eyes look very ugly and fungal eyes look very mild. And so it's very easy to distinguish which is which, and then the appropriate treatment can be instituted with either antibiotics or antifungal agents. Well, she disagreed with me, so we decided we'll take a look. And what we found out is that the clinical presentation of the typical hot eye that we think of with our post-cataract endophthalmitis is not very typically seen with endogenous. The symptoms tend to be blurred vision as opposed to a painful red eye, floaters, and patients in the ICU who are intubated will have no symptoms. The signs typically are conjunctival injection, but that can be very mild and, or a bit more severe, but generally mild. And you may or may not have a hypopion. And if you dilate them, you should see vitritis. Vitritis generally could be mild, where you can still see the disc and vessels, or you may see an abscess. And I would have told you earlier that if I saw something like this, this would classically be fungus, and I'd be right, except that in endogenous endophthalmitis, you can't be sure. It could be bacterial just as well. So what are the clinical challenges? It's rare. It's indolent. Unless you're Malika Das, it's rare. 25% of our patients either had an inaccurate or delayed diagnosis. And yet it can be devastating to vision, and to the systemic prognosis can be very poor, with a 10% mortality rate within a year. And over 55% of our patients had a visual acuity worse than 2200. So the objective of the study that we did at UPMC was to distinguish the clinical presentation and course between bacterial and fungal causes of endogenous endophthalmitis, so that we could help identify features that would aid ophthalmologists in accurately making this diagnosis at the bedside. And so it was an observational case study over a 3-year period, and we excluded patients that could have other reasons for endophthalmitis, such as trauma, previous eye surgery, intraocular injections, etc. And we collected a lot of data: demographics, medical and ocular history, clinical exam, culture data, final visual acuity, and mortality. And this is what we found. In 24 cases, 69% of patients had bacterial infections. 10 cases were fungal. Male, 58%. The average age was 52, but the range was 19 to 86 years. Almost everybody was immunocompromised to some degree, and 77% of patients were known to have sepsis at the time of diagnosis. So that's very important. 77% were known to have sepsis, which means a number of patients were not septic at the time they presented with their blurred vision or floaters or conjunctival injection. The timing of diagnosis after the symptom onset averaged 7.5 days, with a range of 0 to 28 days, and the vision ranged from 20/25 to late perception. The causes of immunocompromised state included chronic oral steroids or chemotherapy, and comorbidities. 27% were over the age of 60. Now you can say, well, if you're over 60, are you immunocompromised? Well, there is this term immunosenescent, and I hate to admit that I fall in that category, because as we age, we don't have the same immune system that we did when we were 20 years of age. In America, IV drug abuse is a big problem. It spans all social strata, economic strata, and it is a big problem, and it represented 32% of our patients. 56% were diabetic, not a surprise, and 23% either had a current history of malignancy or a prior history. 50% of patients were admitted for sepsis and later developed ocular symptoms. 2 cases were detected during a routine exam, and 3 patients presented in the outpatient setting. Our conjunctival injection was seen actually fairly mild, 1 to 2 plus. 22% had no conjunctival injection. Average anterior chamber reaction was 2 plus. 29% of patients were found to have a hypopion, 34% none. So you can imagine how difficult it is to diagnose endophthalmitis without a hypopion. The view to the posterior pole was visible in 46%, and about half the patients there was no view. Culture results were aqueous grew specimen in only 33%. Only 4 of 11 vitreous samples grew positive culture. Vitreous biopsies was a higher yield at 82%, and 1 eye was eviscerated and obviously showed growth. But there was no statistically significant difference in yield between bacterial and fungal cases, regardless of the sampling technique. In almost every case, blood cultures were obtained, and they were positive in 13 of the bacterial cases and 7 of the fungal, and that certainly helps us make a decision as to how we're going to render treatment to these patients. From the ocular cultures already mentioned, 13 of 25 were bacterial and 5 of 10 were fungal. So the management. So 4 out of the 25 bacterial cases were misdiagnosed, while 2 out of the fungal. So even though I initially had the impression that I could make that diagnosis clinically, I was incorrect. And so about 5 patients in the series didn't get any initial antimicrobial therapy based on the fact that we thought it was a non-infectious uveitis. As far as empiric therapy goes, 18 of the 25 bacterial cases are treated with an antibiotic alone, and 2 of the antifungal cases that turned out to be, 2 of the bacterial cases thought to be antifungal were treated with antifungal, and the combination treatment was used in only 5 patients. And on empiric treatment, 8 of the patients, the initial treatment was inadequate. So endogenous endophthalmitis was suspected at the first presentation in 31 of 35 cases, and these patients were treated with intraocular antimicrobials, as mentioned, and this is what we used. And surgical intervention was undertaken in 16 cases, and this is showing us what organisms we were able to culture. And the results showed us that I was wrong. There was no statistically significant difference in presenting visual acuity, symptoms reported, objective measures of intraocular inflammation between bacterial and fungal cases. The pathogenic organism was incorrectly predicted in 28% of cases. 20% of cases were misdiagnosed as non-infectious uveitis on the initial presentation. So it goes to show that whenever we see a patient with uveitis, we have to, in the back of our mind, suspect that there is a potential for endogenous endophthalmitis. The rates of positive cultures were about 50% from ocular and 86% systemic cultures. So blood cultures can be very, very useful in these cases. There was no statistically significant difference in demographics, past ocular history, past medical history between bacterial and fungal cases, and that even included our IV drug abusers. The infectious source did not differ between bacterial and fungal disease, and complications of IV drug abuse also included cellulitis and endocarditis. There were limitations to the study. We did not do PCR testing, which I understand is something that is done here, universal PCR in India, which we do not have available in our laboratory. And so our conclusions are endogenous endophthalmitis has subtle findings. You have to distinguish non-infectious from infectious. History and exam not sufficient to distinguish between bacteria from fungus based on our study. And this is what I think is the key of our study, is that we recommend triple empiric therapy until you have a positive culture, and that we would recommend injecting vancomycin, ceftazidime, and regarding amphotericin voriconazole, I prefer amphotericin, although there are reports of toxicity from it. I've not seen that in my practice, and I think amphotericin is more broad spectrum, but I wouldn't dispute those who prefer voriconazole. And these patients need close follow-up, both from infectious disease specialists as well as ophthalmologists. There's issues with potential recurrence in the same eye or even fellow eye, and the risk of mortality. So take-home message: symptomatic blurred vision, floaters, red eye; asymptomatic fungemic patients, 10% rate of endophthalmitis in asymptomatic screening, unable to provide subjective concerns, but red eye is known in sepsis. A red eye patient in sepsis really needs to have an eye exam, and triple empiric therapy while awaiting culture results. Thank you.
Thank you very much. So much of information, so much of learning. Thank you very much for this wonderful presidential address that you have given, the presidential lecture that you have given us, sir.
Andy, the classic teaching endogenous, they emphasize the intravenous treatment for endogenous compared to intraocular antibiotics.
So it's interesting that a couple patients refused intraocular therapy, and they actually got better with IV therapy alone. So they were diagnosed with floaters, and I don't even know if we did a tap to make the diagnosis, but just said, well, if you have known sepsis, you have blood culture positive results, then this most likely is endophthalmitis, and IV therapy seemed to be adequate in those patients. And I think that's why these patients seem to have a different presentation, as they're partially treated when we see them.
In your EE study, did you give parenteral antibiotics or intravenous?
That was always necessary because of the sepsis.
Any role of steroids? Intravitreal?
I'm a big fan of intravitreal steroids for endophthalmitis because I think that the body's reaction to the infection sometimes is worse than the bug itself. But I don't believe in these cases we did treat with steroids very frequently.
Because your last slide was triple therapy advocated. Well, triple therapy means both gram-positive, gram-negative, and fungi, all three to be covered, till the time you have culture sensitivity results. Yeah.
Sorry, I'm not hearing you.
You said your last slide was talking about triple therapy.
Yes.
Gram-positive,
So that's really my conclusion, which I think is unique in this study, is that we're the first group to really conclude that you really can't tell based on clinical presentation, and that because this can be such a devastating infection, before you have the culture positive results, treat with all three drugs, because I think it's just safer.
Any other question before I request Dr. Nitin to get ready for his talk?
I might ask about the role of vitrectomy, early, late.
What Nitin wants to know is role of vitrectomy in endogenous endophthalmitis, early vitrectomy versus late.
So the role of vitrectomy is difficult because a lot of these patients are sick, and they're not exactly great surgical candidates. But I don't think you have to do immediate vitrectomy in most cases. I think you can treat medically, systemic IV, intravitreal antibiotics, and then watch the eye. And if it seems to getting worse, do a vitrectomy.
Thanks, Andy, for this wonderful contribution and some real good take-home message in the management of endophthalmitis. And your EE study was quite useful in that regard. So with this, we move on to the next talk by Dr. Nitin, the president of Ransco here, and he'll be talking about intravertebral injections and IOP. Haven't heard a lot of talks, Nitin, on this topic, because all of us keep giving injections, and by and large, except in patients who have glaucoma or compromised optic nerve disc, we at least me, does not too much bother about the IOPs. In fact, most of us send the patient directly home after injection.
Excellent. Thank you, Lalit, and it's a pleasure being here talking about various things ophthalmic. I think my talk's really about intraocular pressure and repeated intravitreal anti-VEGF injections. Now, anti-VEGF injections are by nature, things that have to be repeated in most cases, and intravitreal injections have actually revolutionized the management of many common macular conditions. It's now the standard of care, but what we don't know is what happens to the eye and to the body with repeated intravitreal injections, and above all, we don't know what it does with the intraocular pressure. We don't normally check the intraocular pressure after injections, and we also know that we're dealing with an older population, patients with AMD, who are generally prone to pressure problems. We're also dealing with patients with diabetes and venous occlusions, where pressures do have a role to play. And while we check the retinal nerve fiber layer thickness and fields and all that in patients with ocular hypertension and glaucoma, the concomitant macular disease makes it a little bit more difficult to assess many of the parameters. So let's talk about the immediate intraocular pressure alterations. Each time you put something into the eye, whether it's 0.05 mil or 0.1 mil, it causes a change in intraocular pressure, and the pressure can rise to as high as even 80 or 90 millimeters of mercury, and after a little while it does come down. Now, so what? But we know now that repeated intraocular injections or intravitreal injections also cause structural changes, not only to the retinal nerve fiber layer, but also to the Brooks membrane opening, which is really the opening through which the optic nerve joins the eye. And this has been demonstrated very clearly on OCT that even after one injection and even at the end of 1 year, these changes are actually permanent. So, how does the pressure rise? I mean, the first thing you say, you're putting something inside, it's a volume effect. But I think it's a little more than that, because the anti-VEGF injections do alter the VEGF levels in the trabecular meshwork, and we know that VEGF is responsible and necessary for health of the eye and the body. Silicone microdroplets, and other additives in the syringe. Your syringe is quite smooth to press, and they come into the eye, and that can cause a problem too. Many of the drugs that we are injecting are very high molecular weight proteins, which can clog the trabecular meshwork. It can cause an inflammatory response, can cause structural changes, and of course, sometimes we see reflux of the drug, which can also play a role not in increasing but in decreasing the intraocular pressure. And lastly, I think eyes with glaucoma and ocular hypertension have already a compromised facility of outflow, and very often problems with the ocular perfusion. Talking about reflux, when you actually see the reflux after you've given an intraocular injection, first thing you do is take a cotton bud or something and press it, because you don't want the drug to come out and you don't want bugs to get in. Otherwise, you'd have to deal with many of the issues that we just heard from Andrew. Whenever there is reflux, of course, the pressure rise or the pressure spike is less. But the pressure rise can still be significant, as in this particular patient who, after each injection, he kept getting a stage where there was no perception of light, and we would check the pressure straight away, and his pressures were still, as you would consider, quite normal. So initially we started using a little Honan balloon to reduce the pressure before an injection, but perhaps just the use of a standard glaucoma drop, maybe not pilocarpine but anything else, given 2 hours before the injection would reduce the intraocular pressure. Some people like to use Diamox, but a drop is good enough. In fact, by giving a anti-glaucoma medication or an ocular hypotensive drop, you can see in this graph that the pressure rise is blunted. While this may not be important for most of the patients that we deal with, but certainly preventing these pressure spikes can become important in people with glaucoma, with ocular hypertension, with a dodgy or an outflow or a optic nerve head perfusion issue. That's all in the short term, but what about the long term? Many of the pivotal studies for macular degeneration have actually looked and found that the pressure does go up a little bit, but many of them did not address the issue of long-term patients with glaucoma. In fact, if you had elevated intraocular pressure, many of these patients were excluded from the study. But what the current literature talks about is that the overall pooled prevalence of sustained elevation of intraocular pressure is as high as 8.3%, with glaucoma being a significant risk factor. The American Academy Review found that there was insufficient evidence to determine the impact of intravitreal injections on intraocular pressure. And if you look at all the studies, what you see is that they use different criteria, they use different machines, and in fact, they don't assess the impact of glaucoma as a risk factor in most of these studies. So you can see that we don't really have too much information on long-term effect of intravitreal injections. So we decided to have a look at our own patients in Hobart, in Tasmania, and we looked at almost 21,000 injections over an 11-year period. And we sort of looked at what the criteria should be, so any pressure above 22 millimeters of mercury or a rise in pressure of 6 millimeters of mercury on 3 occasions, or any single elevation to above 26 millimeters of mercury was considered as SEIOP, or significant elevation of intraocular pressure. So that's the primary outcome that we've been looking at, but I'll address some of the other issues that come up also. Looking at the demographics, as expected, most of the patients, or the majority of patients, were in the AMD category, followed by diabetes and retinal vein occlusions. We had 64 eyes with glaucoma, and what we found was, just get this out of the way. Yeah, we found was that compared to other studies, the diabetics pressure rise was about the same, but in our study, we found that macular degeneration, the pressure rise was not as much as the patients with diabetes. And in fact, in many of the, when we looked at these cohorts, we found that the confidence intervals were fairly large and with an overlap with normal eyes. Looking at the drug that was injected, you sort of say, well, which drug is the culprit? Well, we found that there was no difference, although the Fight Retinal Blindness Registry from Sydney, they found that ranibizumab or Lucentis had a higher chance of intraocular pressure rise as compared to Eylea or aflibercept. The factors of significance: pre-existing glaucoma, ocular hypertension, and phakia. So pseudophakia is a protective factor in this situation. Now here's an example of a 72-year-old male with AMD on treatment, given ranibizumab over all these years. He held his glaucoma indices very well, as you can see here. This is ocular hypertensive. Somebody with glaucoma on treatment with travoprost and been given Avastin or bevacizumab with pre-existing defects, and you find that they hold on quite well, although there's a little bit of deterioration. In a third patient, who is a one-eyed patient, much older, and has got diabetic macular edema secondary to a retinal vein occlusion. For many years, the macular thickness and vision stays constant, but with time, the pressure, as you see on the green points in his left eye, which is his only eye, the pressure has been rising slowly. And now he's on maximal medical therapy, and given that he's only one-eyed, he's very scared of getting anything done. And in fact, I had a job to convince him even to have an SLT done. These are his glaucoma parameters, and these are his visual fields in an only eye. So when I get back to Hobart, I've got to figure out something for him. But you can see the dilemma that both the patient and me as treating him have. So if you look at where this whole thing lands up in the big, as compared to other studies, you see this blue part, which is where we are, and I think we see that pressure rise is a problem. We also see that we've got 27 patients with, with glaucoma, and I think that this perhaps is an important thing in trying to figure out what happens. Answers to some other questions, not from our study, but otherwise, is how long does it take for the pressure rise to occur? 1 year, 2 years, and it's generally about 1.5 years. Looking at the diabetes, you find there always seems to be a higher incidence in diabetic patients, and it's quite often correlated with the HbA1c. The facility of outflow is another factor which is already compromised in patients with ocular hypertension and glaucoma. And in fact, the facility of outflow is always reduced in patients who are getting frequent injections and also at shorter intervals. So if the injections are less than 8 weekly, you find that the facility of outflow gets affected, as you see in this particular graph. So not only the number of injections, but also what the pressures are like. You see on the right side, we see the facility of outflow is down. Now, no talk can be complete without talking about genetics, but I think in this situation, while we have identified a gene, perhaps there's no reason to start worrying about genetics in the start. Lastly, the issue of the syringe. Now, there was a cluster of syringe-related problems in Canada, where the pressure went up and they found that there were silicone microdroplets coming in. And also once they started using silicone-free syringes and also filtered anti-VEGF agents, that these pressure problems came down. The new Eylea formulation is in a pre-filled syringe, the barrel of which is much broader than the Lucentis one, and we are quite used to giving a good bit of pressure on it. But I think we initially observed a lot of pressure spikes with Eylea pre-filled syringes, and that was important to try and make sure that the plunger and the line that's drawn on the syringe are properly aligned, and at the end of it, the injection is done without too much pressure. So gentle injection, and you find that you don't get pressure rise. So finally, I think we had a fairly obvious and positive message to give, where 117 subjects developed sustained elevation of intraocular pressure, and in our study it was not related to the kind of treatment that was given. The SEIOP was associated with pre-existing disease and lens status, where glaucoma patients had a 3.5-fold increased risk of pressure rise, and pseudophakia reduced the risk of developing increased intraocular pressure by almost 40%. So I think if there's one take-home message is that you need to think about intraocular pressure in patients whom you're treating with repeated intravitreal injections. You know that structural changes occur. You know that this can affect the retinal nerve fiber layer and the perfusion of the optic nerve. But I think if you want to treat an eye, not just the macula, you need to put this into perspective. So the challenge, of course, remains in identifying those patients and monitoring them more closely. Thank you. That's a view a few days ago at my place where we just had snow, so I'm really enjoying the weather here. Thank you.
Thank you, Nitin, for this. Actually, we trivialize this procedure so much that we hardly bother for this IOP changes. Honestly speaking, except in patients of glaucoma or patients where optic nerve is compromised, maybe in diabetics or rest of the patients, most of us don't bother about this IOP rises. We used, once we started a decade or more than a decade back, we used to see, before the patient goes home, after giving injection, he does get the pulsations and optic nerve status seen, and we do NCT and then send him home. And we found that by and large these pressures come down over next 3-4 hours. It's not a sustained rise. So as of now, at least in our practice, my practice, we have stopped miring. We directly send the patient home. So what is your final take? Except I saw your last slide that pseudophakic, protective, and patients who have glaucoma. Obviously, in such patients we sometimes do paracentesis also, because we don't want any insult to the optic nerve.
Yeah, it's a difficult problem, as I highlighted in one of my patients, where you've got a compromised circulation, trabecular meshwork, and also macular disease. I think these are the patients where you've got to be very careful to make sure that you reduce the baseline pressure before an injection and keep the patient at least for half an hour or 40 minutes after the injection to make sure that the pressure has come down before they go. It's standard practice, at least where we go, is to at least check that the patient can see your hand and, and then
So
get them off the table.
In all these patients, will you give acetazolamide or some pressure lowering agents?
No, not for all patients, but compromised patients where there is glaucoma, they can get a drop of whatever they're using, sometimes a beta blocker or apelacrondine, anything, and they all work very well.
You see, your patient number 3, who said he was doing pretty well, and after some time he had a worsening of the status. Was it a natural, his own glaucoma disease, or related to pressure, related to injections?
I suspect it's a bit of both, but here's a patient with a retinal vein occlusion where intraocular pressure has a role to play. His glaucoma is obviously converted from ocular hypertension to glaucoma. That's very clear. I don't think the pressures, the injections have caused that. But the dilemma right now is how to manage him. Because each time you inject something inside, his pressure is going to shoot up, stay down, and he's got such a fragile optic nerve head perfusion. And I'd be very careful in suggesting that each time he has something that we do a paracentesis. So we must try and do whatever we have to do in a non-interventional way.
Can I just add one point? Very interesting point you raised. I have seen my patients who've been on long-term therapy for polypoidal in both eyes. The pseudophakic eye did not develop surprise pressure rises, but after repeated injection, the phakic eye did. And what we have been mostly following, we have avoided use of prostaglandin agents, but we have put them on agents which increase the outflow along with the beta blocker.
Yep. No, thank you. I suppose.
Can I make a comment? Yeah. I think that some patients get glaucoma or cupping without sustained elevation of eye pressure. That just the fact that we're injecting them monthly can affect that over a long term. And I think as retina specialists, we often look at the OCTs, but we forget to look at the retinal nerve fiber layers. And all of a sudden, 3-4 years later, you say, oh my God, this is a really, a lot of loss, a lot of cupping. And yet you measure the pressure, and it's not that particularly elevated, maybe 18, 20, and you wouldn't necessarily call it glaucoma by the, pressure alone. And when you look back, the pressures really haven't changed. So you wonder if it isn't just simply the injection itself. I probably do an AC tap on about 10% of my patients.
No, it was good. I think there is evidence that there are structural changes that take place. But I think in such patients it might be a good idea to do a retinal nerve fiber layer thickness and a field just to be on the safe side every now and then. Well, if it's just a cupping with no functional or structural changes to the nerve fiber layer, I think you're pretty safe.
Dr. Nitin, a short comment. We in India, we have comprehensive ophthalmologists, and now that the OCT and the understanding of medical retina is percolating to a very large population, especially in India, so we have our comprehensive ophthalmologists giving anti-VEGF. And I think it should be a very, very practical pearl to see that the amount of injection that goes into the eye is what is required and not more. We do not have the prefilled syringe of Eylea that you were alluding to here. And Eylea, we get a little more than what is required. So, being understanding of the fact that this is an expensive drug, there is a possibility of injecting the whole of the vial. And then that can cause a huge rise in pressure. In fact, I inadvertently did 2 in which there was a pressure rise, and the patient said, I can't see anything, doctor. And I think that is something that we have to be very particular on and inject exactly as much as is required, not more.
Yeah, no, certainly it's a volume-related effect, yes, for sure. even though when we inject triamcinolone, we inject 0.1 mil rather than just 0.05. But that's no, I think you need to read the instructions.
Yes.
But the main, when you will get pre-filled syringes, there's no doubt about it. The main thing is to just inject probably from the mark, and also don't push, because you can put in 25% more if you are really very enthusiastic. So I think once you follow that, there'll be less surprises.
Okay, thanks, Nitin, for highlighting, a often neglected, aspect of intravitreal injections. So let's move on. Let's hear Andy again about the scleral buckle, because as experience with MIVS is increasing, a lot of people have shifted their approach, and even for surgeries which are buckleable, people still go inside because of ease of doing and not straining their back and a lot of other things. So let's hear from Dr. Andy about the buckle part, scleral buckling.
Good morning again. Yeah, it's kind of funny to me talking about encircling buckles, because I trained with Dr. Scapins, who never did encircling buckle alone, which in Europe they call a cerclage, which I think is kind of a fitting description for an encircling buckle. But let's talk for a minute about what are the three principles that are involved with the repair of a retinal detachment. Number one, we localize the break. Number two, we must release the vitreoretinal traction. And number three, we create a chorioretinal adhesion or scar. And so those are the principles, but there's different ways that we can affect those principles. You can localize with a chandelier using the operating microscope. You can localize with an indirect ophthalmoscope. You can release the vitreous traction with a vitrectomy or with a buckle or both. And you can create an adhesion with diathermy, laser, or cryo. But what have we learned from pneumatic retinopexy? What we've learned is that you can repair a detachment in many cases by just applying two of those three principles. When we do pneumatic, we localize the break, and we create a chorioretinal adhesion. But the gas bubble does not eliminate the vitreoretinal traction. And in fact, pneumatic retinopexy only works if there's limited persistent vitreous traction on the break. If there's too much traction on the break, your pneumatic retinopexy will fail. And that's really one of the principles of identifying the correct patient for pneumatic retinopexy, is by trying to estimate how much residual traction is on the break. So the bottom line is, as I think about it, is that if I can fix a number of patients by applying just two out of the three principles, do I need a permanent scleral buckle in all cases? And if I don't need, and if I even need a buckle, how high does it have to be? So I'll make those 2 points. Now, what's the history? Scleral resection was done by actually undermining the sclera and creating a buckling effect. And then later, Aruga in Spain talked about the Arugula Suture, which could be nylon, silk, supermid, and it was just basically creating a dam or an encircling buckling effect just posterior to the break. And the problem with those is that there was a lot of intrusion, and you could have a detachment persistent anterior to that buckling effect. And then Scapins started with the polyethylene tube, and then later the silicone band. So this is a typical Scapins type of buckle, a tire, a very broad tire. And the Scapins principles are basically, or we call the Boston buckle, is you localize the break, you place the break so that it's in the middle of the span of the tire, and you buckle the extent of the detachment, but trying to avoid buckling more than 180 degrees. So that's basically the principles of a Scapins buckle, and that the encircling band that goes through the groove is just gentle enough to keep the edges of the buckle down and hold it in place without losing your height. But why do we use an encircling buckle? Well, we know they work. They're fast. You don't have to have precise localization. And in skilled hands, it's very low risk and it's very inexpensive. So we like to do the encircling band. And so here's an encircling band. Usually it's about 2 to 3 millimeters behind the muscle insertions. This is a little bit further back. I prefer to anchor it in place with a nylon suture. Some people will use Vicryl. Some people do belt loops. I have a problem with belt loops because sometimes I place it with my suture and I don't like the position and I cut the suture and replace it. If I make a belt loop, it's harder to adjust. And also I don't like to thin the sclera any more than it's already thin. So what is the mechanism of a buckle? Why do we do this? How does it work? Well, it reduces vitreous traction, but it also reduces the currents within the eye. So here's from a paper of Scapin's, here's the vitreous traction, and a buckle indenting the wall of the eye here is going to release that traction. But there's another mechanism, and that is the fluids. As the eye saccades, moves up and down, there's fluid currents in the eye, and the fluid currents get underneath the retina and elevate it. And so by placing a buckle on the eye, you're not only reducing the traction, but you're also affecting how the fluid currents work on the eye. So there's two major effects. So I will not talk about, in this presentation, about detachments in patients who are younger who have no posterior vitreous detachment. I think that is the one indication where a buckle alone is quite sufficient to fix these eyes. And so the PRO study group excluded all patients under the age of 40, therefore trying to identify only people that have had a posterior vitreous detachment as the underlying etiology of their retinal detachment. And so, and what you can see in their various reports is that in the phakic patient, a buckle alone versus a buckle vit were similar, whereas a vit alone was not nearly as successful. In their pseudophakic patients, in all cases, whether it was a superior detachment or an inferior detachment, vitrectomies alone had success rates in the 80%, whereas vitrectomy buckle was in the 90%. And this is something that I don't think anybody likes to brag about the results of their retinal surgery, as that is inferior retinal detachments. Superior detachments are easy. You put a gas bubble in the eye and the patient sits up. But inferior detachments, due to presence of gravity, that's much more complex. And you can see that vitrectomy alone with inferior breaks had a 76% success rate, whereas vitrectomy with buckle was 87%. So still not in the 90s, but certainly much better. So how do we apply the buckle? Well, I already showed you some images of that, the different components that are available, the 240, the 41, 42, 40, 50. I prefer the 41 band. If it's a very large eye, I'll use the 40-50, which is a 5-millimeter strip. But that's kind of personal choice. You can place it about 3 millimeters posterior to the muscle insertions, belt loops versus sutures, a Watzke sleeve versus a clove hitch, and the clove hitches can be nylon, merceline, or polydioxanone. And so one pearl that I want to give you is that I think it can be very easy to over-tighten a band. And then you see the patient post-op and you say, oh my God, what was I thinking? This band is so high. And what happens there is you also increase the myopia quite a bit. So one of the things I like to do is create what I call a happy band. So first of all, I pressurize the eye. If I'm doing a vitrectomy and applying the band after or during the vitrectomy, I raise the eye pressure to 60 while I'm adjusting the tension. Therefore, I don't overly tighten the band. And the second thing I do is I just pull on it a little bit, and I want it to be happy. I don't want it to snap back against the eye too vigorously. There's a lot of different tricks to avoid making it too tight, but this is the one that I like. And again, here are the different bands you can use, different styles. And although this is the tire, if you use the broader band, the 40-50 or a 40-60, you can imbricate it as you would with a tire and get some height in that one area, and yet you can still encircle using the same element. And that's, that gives you the advantages of both an encircling band and the tire effect. And also, if you use an encircling band, but the break is a little bit posterior, you can use a meridional implant, such as a 112 or a 109, and put that under the band. So I thought I was very unique and very clever in saying, well, do we really need a permanent band in every case? And I think it really depends on the status of the vitreous. If you're doing a vitrectomy and it's really sticky, broad-based vitreous, I think I might want more of a permanent buckling effect. Whereas in most cases, if I can do a good vitrectomy, I want to have that high percentage success rate that we get with a vit buckle, but I don't want the lasting myopia, particularly when patients are pseudophakic and they've paid a lot of money to have their premium implant lenses with the multifocal lenses and so on, and then permanently screw that up with a very tight buckle. So I thought I was very innovative in using a releasable knot, but instead I found this paper from China. But this is a clove hitch. It's a sailor's knot, a mountain climber knot, and this is a suture I tend to use, which is absorbable. It's a type of Vicryl, but it lasts a couple of months, maybe 3 months, before it totally dissolves and reverts the eye back to normal configuration. So you get the height of the buckle initially. I think you get the very good success rate with it, but then you don't induce so much myopia. And this is how you can tie it. If you're not good at sailor knots, you can just simply wrap the suture around. Another pearl I'll share with you is that when you pass a band around the eye, if you cut the ends so that they're matching, when you encircle the eye, both cuts should go the same direction, and that way you know the band's not twisted. So it's another pearl for you. What to avoid? A tight buckle can cause intrusion, the myopic shift, acute glaucoma, particularly in hyperopic eyes. A very broad buckle can cause a choroidal detachment, particularly in older people, and a tight buckle can cause anterior segment ischemia. Obviously, you want to be very careful making your belt loops or your suture passes to avoid hemorrhage, endophthalmitis, or inducing a retinal break. We always say that when you're working with trainees, with fellows, you let them pass their sutures over the area of detached retina first, not over the area of detached retina, not attached retina, so they don't make a break, at least if they perforate. And here's some images of patients who've had encircling bands, and you can see the silicone through the overlying retina. And this does not make me happy when I see this. And I usually go back. I would never remove the bands, but I will go back over the Watsky sleeve when I see someone like that and just cut the sleeve and relax the band. And you can see when you cut it, it just goes whoosh and retracts very quickly. Fortunately, none of these are my cases. These are patients that I've inherited. And what you're looking for when you see a patient with a tight band is you're looking for these pigmentary changes that are not from cryo. This is just from the pressure of the band itself. And when you are following somebody with a tight band and you start seeing these pigmentary changes, that's when you know we have to go back and cut the band. And here's a patient that had a tight band and they still had a retinal detachment posterior to it years and years later. And here's a tight band, again, with the pigmentary changes. And this is a patient who has a very high 360 buckle, and it's not intruding by any means, but I don't think it looks very good from a artistic, if you will, standpoint, certainly much higher than you need. And this is a polyethylene tube from the Scapin's era. This is a patient who had retina surgery back in the 1950s, and she had recurrent vitreous hemorrhages from this tube, which I elected not to touch. And this is an Arugula Suture, and you can see that it just creates like a dam effect, but very often the retina is detached. Has anyone ever seen an Arugula Suture? I saw one patient from Bulgaria years ago, and it had intruded under the retina, and she was having recurrent hemorrhages, and I elected not to touch it. But anyway, those. I thought I'd share my experience with encircling bands with you. Thank you very much.
Old given school coming alive with good Clavich suture. It reminds me a lot about my fellowship. Do you really think it's a good idea in pseudophakic eyes to put in an inferior buckle if one wants to do a vitrectomy? Well, pseudophakic eyes, it's nearly 100% vitrectomy now in our country. And most of us are using, it's only in myopic eyes that we put in a inferior 276 support 180 degrees. But then you have in your own country another group which doesn't believe in buckles at all. So I want to know your thoughts on it, and Nitin can also give his thoughts.
I have a partner who has never done a buckle in his life. And if he has a patient who is young, who does not have a PVD, he'll actually refer the patient to me for a buckle rather than do a vitrectomy in that case. But so he has a very good success rate doing vitrectomy alone for inferior detachments, but he uses C3F8 and he keeps the patient positioned for a week or two. I find that by using my buckle, and I like a 276, but I will also encircle using a clove hitch that dissolves so they don't get persistent myopia, and I can use SF6 or even probably just regular air, room air, and maybe positioning for a day or two and send them back to work. So I do think I have a high success rate with that.
Well, the last time I did a retinal detachment was 22 years ago, so I don't think I have much use, but I can tell you this much, that we run a program in East Timor, in Timor-Leste, which is a very small country near Australia. And in introducing retinal detachment surgery there, we've gone straight for the buckle, because that's something that's doable, it's affordable, and it works.
Before Dr. Nitin's talk, I would like to have two quick perspectives on the same question from Dr. Sangeet Mittal, who practices high-volume retina in Punjab, and from Dr. Gadre, who practices a good volume retina in Gujarat.
So one of the indications I do buckle is the configuration of the retina, which is sometimes called zipper syndrome. When you are doing a vitrectomy, sometimes you see there are multiple horseshoe tears which are spread all over the temporal retina. And in those eyes, we generally found that there's a band like vitreous which is attached at the vitreous base. I know in those eyes, I've found that if we only do vitrectomy, it leads to very high failure rate. And in those cases, the encircling band is very useful. That is one place I generally do an encircling band.
Dr. Gadre?
Thank you.
I follow whatever is the general trend actually. Whenever in doubt, especially about inferior tears or PVR mainly restricted in the lower half, I give support with an encircling band.
If there are no other reflections and questions, can I request Dr. Nitin Verma to deliver his talk on sustainability in ophthalmic practice. The time to act is now.
Well, thank you. Totally different, but often related to everything that we talk about in ophthalmology. So thank you for asking me to come and share with you something that doesn't have p-values and stuff like that. So really it's talking about sustainability. By definition, sustainability is defined as meeting the needs of the present without compromising the ability of the future generations to meet their own needs. What I talk about is a number of things, not necessarily in this order, but perhaps anything to do with sustainability has to start with climate change. So what does climate change really mean? It means unusual weather patterns, whether it's rain, whether it's temperature or extreme weather events. And many of these things are related to this greenhouse effect where the earth radiates the sun's heat and is trapped by greenhouse gases and warms the earth. So very simplistic sort of explanation. I don't think that it's all of it, but what it's done is over the past 2,000 years has caused the temperature of the earth to definitely increase alarmingly, not in the usual predictable pattern, but certainly something more than that. And if you look at this map of Australia, you see that the temperatures are rising and the rain patterns are decreasing. So we are confronted with bushfires, we are confronted with drought and also floods at the same time. No country is immune, not even India, where you had a heat wave where the temperatures have gone up to beyond 50 degrees centigrade. And in fact, if this continues, you will have unusual patterns of rain, you will have unusual water level rises including Mumbai and other coastal cities, and also a large impact on food production, so much so that it's estimated that up to 63 million people may not be able to meet their caloric demands for what is required to live. The children are going to be even more severely affected because the life of every child born today will be affected by climate change. And unless we do something, this is going to be an impact on the next generation. So whether it's heat, whether it's increased dryness, whether it's increased pollution, whichever way you look at climate change, it's going to impact health, but it's also going to impact the eyes. There's going to be more trachoma, more vitamin A deficiency, more allergies, cataracts, name it. And I think that's going to increase the dependence on health systems. It's going to change our lifestyle, and of course it's going to affect mortality and, eyes and vision and morbidity. So it's going to have a long-term effect. So wherever we start on climate change, whether it's, pollution or plastics or whatever, it's going to have an impact on public health, on our well-being, and also on the social quality of our society. So it's all very good making statements like this, but the thing is, what should we be aiming for? Now, the different models, the SSP models, and I think we really need to be going at a sort of middle of the road as discussed in 2021 in Glasgow. So at least that gives us an aim. Okay, what are we aiming for? As healthcare professionals, and this is from a paper by David Cheng, who's very well known in the cataract world, healthcare is responsible for almost 10% of greenhouse gas emissions. And we know that ophthalmology is a very high volume, surgical specialty. Amongst cataract surgeons, and I think also amongst people who do a lot of intravitreal injections, there's a feeling that we are, so bound down by regulation, so bound down by the industry, we're so bound down by so many things that we perhaps are producing too much waste. And in fact, if you look at it, the published data from India, from Arvind, the eye care system, the post-operative endophthalmitis rate is less than the post-operative endophthalmitis surgically in the United States. So something is not right the way we are going, and I think we need to address that. Healthcare, as you know, is a serious emitter of carbon, and we really need to look at how ophthalmology can reduce our carbon emission without compromising patient care. Now, this is an example or a map of a part of New Zealand, and the little red area at the bottom is Wellington, the capital. So in New Zealand, we have the same problems of distance. People live far away from the center. And there are older people living in retirement homes and find it difficult to move. There are country hospitals, there are rural hospitals, but for injection, all of them travel down past hospital facilities, past clinics, all the way down to Wellington to go and get their injections. So, I mean, you'd say, well, why don't you put clinics in on the way or bring people to rural clinics? So obviously we need to address this issue of manpower in countries to reduce the carbon emission and carbon footprint. What about the other culprit, cataract? Now, it's possible to look at the carbon footprint of cataract surgery. You can calculate that. If you look at these figures here, these are the figures from the National Health Service in the UK, and you can see the carbon footprint of a cataract surgery as compared to this little 6 kilogram of the Arvind systems calculation. And if you look at New Zealand, it's a little bit less. So what does this mean in real life? 152 kilogram carbon equivalent is how much one person who lives for 5.9 days produces. It also amounts to the same amount of carbon that is produced by burning 67 liters of petrol. So you can imagine that you think cataract surgery is benign, you think it's innocuous, but actually it's not. It has a great impact on climate change, and also, so it doesn't matter whether you use renewable energy, that's why New Zealand is a little bit lower in the carbon production, but really we've got to look at other parts of the journey for cataract, and one of them is procurement. Now, we have consumables that are double packed, triple packed, for whatever reason, but we must think of addressing this along with industry to reduce the consumption and to reuse and recycle. Thankfully, the most important fact is that the commonest form or commonest mechanism of removing a cataract is thankfully not phacoemulsification. If you take the global picture, it is small incision cataract surgery in whatever form you use it. Because not only is it cheaper, its carbon footprint, because less reusables, less disposables, more reusables, and so on, it's much less, and the results are getting even better and better. And to this end, I'd like to point out the International Society for M6 in India, which is an Indian initiative, the job they're doing, and also Help Me See, which have got a surgical simulator for M6, and I think that that's really going to be pivotal in improving the outcomes of M6, and also at the same time ensuring good quality outcomes and reduced carbon. In Australia and New Zealand, there's a move to stop using post-operative antibiotic drops, which are all in plastic bottles, because after the use of intracameral antibiotics, endophthalmitis is reasonably well controlled. So it's all very good. And I'll leave you with intravitreal injections again, which have now overtaken cataract surgery as an important, not only procedure, but also an important emitter of carbon. So look at what you do and see how you can reduce the carbon footprint of a simple thing like an intravitreal injection. We operate in theaters, and if you look at this photograph of the theater, you'll see so many things in blue which are all disposable. We should look at the lighting we use, we should look at the, what we leave on at night, the air conditioning and so on. So there are so many things that we can look at in trying to reduce this carbon footprint. So to summarize, it's always about reduce, reuse, recycle, but to that I would add rethink and research, because that's the key to going ahead. As ophthalmologists, we also have administrative functions. We have business functions. We run departments. We run hospitals. We run hospital chains. And we are also running businesses. So there's no point in running a business which is not sustainable. Otherwise, you'll never be able to deliver eye care in the way you want to deliver eye care. And I think as an ophthalmologist, as a doctor, you need to be a good manager, understand finance, understand cash flow, understand all these things if you want to run a sustainable practice. For those of you who run eye care systems, I think an article by David Green has been very I find it very good, where it looks at economies of scale and all that kind of stuff, which will help you keep sustainability at the forefront of what you do. In this context, I think India and Nepal lead the way. The Arvind Eye System, the LV Prasad people, the Chitrakoot hospitals, and the hospitals in Nepal, which has got a very good public eye care system, are global models that can teach even the developed countries, when I say in inverted commas, a lot in terms of sustainability. So what about charitable sustainability? Now, Mohammed Yunus, you all know, the guy who talked about microfinance from Bangladesh, he talks about the charity dollar. Now, we often say, well, I've given to charity, leave me alone, let me be. But the charity dollar is a one-off thing. You give $10 or 10 rupees or $1,000 or 1,000 rupees, and it's a one-off, it's gone. But if you convert that and question how your dollar is being used or your rupee is being used, and say, I want to convert this into a charity business dollar, so that ultimately your charity dollar or your charity rupee will go a much longer way, which will add on to sustainability even in the charity sector. Other aspects of sustainability include gender balance. Now, the UN report from 2020, the Women Report, shows that males are still dominating, whether they're parliamentary positions, whether they are managerial positions, and this is not sustainable because men are not the commonest gender in the world, We've got women also to consider. And I think a target of 50% ultimately, but really for us, we set it at 35% in Australia. We've reached that, and we aspire to go up to 50%. Remember, diversity and inclusion are other causes of imbalance which need to be addressed. A workforce needs to be addressed. We need to make sure that we can keep our workforce going so that what we do remains sustainable. During COVID, we've learned a lot of lessons, including working from a distance, working from home, the use of telehealth, and also I think artificial intelligence is going to have a lot of role to play as we move on to the future. It's all very good to talk about this, but nothing is going to happen without political involvement. Nothing is going to happen without political will, and nothing is going to happen without political sign-off. And I think the recent elections in Australia have shown this. The previous government, which governed for 10 years, was kicked out because they did not have a good climate change, a policy that addresses climate change. Telehealth is again something to consider as we move on in the future. Remember, in your pocket, in your purse, in your bag, you have a computer that you're carrying all the time, which will be useful, as will be home monitoring devices as we go along. So what have we done as a college? What have we done as a profession in Australia? First of all, we did a survey and found that most of our people were very savvy and wanted something done about climate change. In fact, women and younger ophthalmologists were very keen on this. People who are living in remote and rural areas were not very keen on this. Now, we'll have to find out why. And also, they believe that medical organizations like ours have a great role to play, and that we should hold public hospitals accountable and put sustainability as a key performance indicator. So while the United Nations has got 17 Sustainable Development Goals, we as a profession have adopted and embraced 8 of them which are relevant to us. We've launched Vision 2030 and beyond, which is really a vision for the future involving the whole workforce, where we are looking at 6 pillars of that support Vision 2030, and one of the most important pillars is sustainability. We are involved with advocacy at both local and national and international level. We have a magazine called Eye to Eye, where we put articles on sustainability on all the time, and absolutely no hesitation in highlighting good examples such as the Arvind Eye Care System, which all comes from India. We have clinical guidelines on reduction of waste in cataract surgery, which I just signed off this morning, so it should be available on our website. So sustainability is supported by a Women in Ophthalmology Committee, a Diversity and Inclusion Committee, which really goes on how the whole organization of RANSCO is governed. So future pathways for us will continue to advocate. We would look at deepening our engagement and would also always be looking at innovations. As individuals, you can do a lot. See what you do in your life, see what you do with your family every day, and see what you can do. As a profession, it's not only ophthalmology. We need all doctors to act, because I think if you want to move ahead, we need to shape the future, not let the future shape us. So the time to act is now. So I challenge you, get on with it. Thank you.
Thank you very much, Nitin, for a very interesting talk which gives a lot of food for thought. And I feel Arvind Eye Care System, Chitrakoot, both have led the way in not only volumes but sustainability. And it's also heartening to put on record that a lot of Indian high volume practices also have a recycle system for a lot of consumables, which is ruled by the economics of the country. Of course, with all the safety standards. Anything from the audience? Would you like to add anything, Dr. Andrew?
I'll just say that it's interesting. When I started in practice and as a resident, the tubing we used for vitrectomy was silicone, and the silicone tubing was flushed and sterilized and reused. And I'm sure the companies came out and said, well, that's not sterile, but they realized also they couldn't make any money. Once they sold a vitrectomy machine, that was one sale. But now we pay, I think, $600 for each vitrectomy pack. And in our hospital, probably between 20 vitreous surgeons, we probably spend over $1 million a year in vitrectomy packs, which fills a lot of landfills. And you wonder if that really does have to be disposable as it is. They couldn't be reused, flushed and reused a couple of times. So it's one thing if it's an endophthalmitis case, but it's another thing if it's just a simple vitreous hemorrhage. Are you reusing any packs at all in Australia?
I think what we're doing is we are still stuck with regulation, and I think we need to look at regulation, because regulation, it's like the tail wagging the dog. You know, we really need to look at what we do, and we need to challenge what we are told to do, and that's really what's happening now.
Another question, are the high volume surgeons using reusable diamond knives as opposed to steel blades here?
No, it's mostly, if reused, they are all ETO or plasma, sterilized. So it's packed. Yeah, definitely it goes into a pack or a double pack, and then it's ETO or plasma. That's what's the trend in the country. I don't think diamond knives are that popular now. It's mostly blades.
Plastic at the end of it.
Yeah.
Okay.
So it has been a very interesting session, and thanks to Professor Andrew and Nitin for taking out the time and being with us. Thank you very much. Hope to see you again next year.
Thank you.
And Nitin,